launched this for all of our SADS families 3 weeks ago today on March 20th. And this is our 5th session. And today I'm joined with a dear friend of mine and a wonderful colleague and just a beautiful person, Dr. Elijah Behr from London in the United Kingdom. And so Elijah, it's great to have you join us. And before you give us a feel of who is Elijah Behr, I just wanted to let our SADS families know what we're here for, and really want to thank you all for joining us. Thanks to Alice Laura, the CEO of the SADS Foundation, for putting this together and for knowing that it is a need out there and we're trying to meet your needs. Your questions have been amazing over these past 3 weeks, and Elijah and I are looking forward to seeing those questions again today. For those of you where this may be your first session with us, welcome. And so we may be repeating some of our recommendations and encouragement that some of our faithful followers who've been here since the first segment have already heard. We are obviously in COVID-19 pandemic. I think there's some good news. I think the worst is behind us. At least that's what I see in many countries across the globe. We are tragically have crossed the 100,000 death mark across the globe for COVID-19 mediated deaths. We're approaching 500,000 cases in the United States and 65,000, 66,000 cases of COVID-19 in Dr. Behr's country. There are about 18,000 COVID-19 deaths in the United States and about 8,000 in the United Kingdom. So it's not surprising now that some of us know someone who has died from COVID-19, and that's certainly true for Elijah Behr and myself. So welcome. And Elijah, tell all of those listening, who is Elijah Behr?
Well, first of all, Mike, I just want to thank you and thank SADS for inviting me to participate. I've been involved with SADS for a few years now and been at your conferences and spoken at them, and it's been a real pleasure to do that with you and your colleagues and with your families and meeting them. I'm similar to you. I'm a cardiac geneticist and I'm an electrophysiologist as well, based in London at St George's University Hospital's NHS Trust, and also in the university there. I do research as well around cardiac genetic disorders and unexpected and unexplained sudden death. And therefore, Mike and I, we share a great interest in this area and how best to help families, particularly at this very worrying time. And as you say, we are countries dealing now with a great challenge, and we're making headway, but we're making headway hopefully in partnership transatlantic as this broadcast shows. So thank you again, Mike.
Great. Well, thanks, Elijah, and welcome. Give a sense of how you see COVID-19 occurring in London and in England. What's the current state of things in your country?
Well, at this point, we still haven't really hit the peak of infections and mortality rates. I think we seem to be getting a slowing in the infection rates, and that's encouraging, but we still haven't hit that peak as far as the death rate goes. We think that's going to be in around 1 to 2 weeks' time, so after Easter. We do think, however, that we've managed to, as they say, flatten the curve by putting in effective lockdown measures, by ensuring that people are social distancing and reducing the chance of transmission, particularly to the vulnerable, that we are able to slow that progress and allow the health service to cope a lot better with the number of patients with COVID, but also to try and cope with patients who don't have COVID and who have other conditions such as heart attacks, cancer, stroke, etc., who can therefore still. I think we're managing to deal with that and get to grips with that, as well as have enough capacity for the crisis.
That's great. That's good news. And Elijah, you and your colleagues, I know we had Arthur Wilde, a dear friend of both of ours, with us on Monday. But you and Arthur Wilde and other colleagues, and you with your various roles in England and with inherited arrhythmia conditions, have put out some guidance, some important things for our SADS families. And, you know, many of our listeners heard some of those already, but for those who might be joining us new for the first time, what's the one most important thing you want our long QT families to know with respect to their long QT and coronavirus COVID-19?
I think the most important thing, other than, of course, social distancing and reducing the chance of getting infected, the most important thing is to be able to inform your doctor that you have long QT syndrome and make them aware of the potential risks of any medications that they may be considering using to treat COVID, given that there are these medications, hydroxychloroquine, chloroquine, azithromycin, and some of the other antiviral drugs that can have interactions and affect the heart and the electrical capacity of the heart to reset itself, repolarize itself. Long QT syndrome is a potential predisposing risk. And as long as you can transfer that information to your physicians, then I think that's going to be a very important way of reducing any risk associated with your treatment.
Yeah, that hit list of drugs to avoid that we tell our long QT families, www.qtdrugs.org. You can also get there from www.crediblemeds.org, is really important. What about Brugada syndrome, Elijah? What's the one most important message that you want to make sure our Brugada syndrome families never forget as it relates to COVID-19?
Well, as many of these families are probably aware, an increased body temperature, a fever, can increase the risk for rhythm problems for some Brugada patients. Now, thankfully, that risk is generally low overall, although some patients will have higher risk than others. So the most important thing to remember is that as soon as you have any signs of fever developing, that you should be taking acetaminophen straight away and try and ensure your temperature is brought down. If your temperature is, however, still staying up despite those concerted efforts, cooling yourself down, cold compresses, etc., and it's not working, then you should definitely get in contact with either your emergency department or your EP physician who looks after you so they can give you some more advice. We have published information in some European guidance, has also been shown in Heart Rhythm Journal and in the UK as well through the Association of Inherited Cardiac Conditions. And there we list some patients who may have higher risk than others. But thankfully, as I said, most will have low risk.
Great. Thanks, Elijah. Well, you know what we're going to do is we're going to go right to the public and look at some of the questions that are coming in. And thanks for submitting them. We're going to go through as many as we can. Amanda is asking us about how our QTC monitor is coming. I'll take that. It's coming along really, really well. We're very excited. The FDA has granted emergency approval of QTC monitoring with AliveCor's cardiomobile device. And as many of you know, long BC, before Corona, AliveCor and Mayo Clinic had started to partner together in 2017 to create a QT solution with their device. And so progress is being made. If there's time at the end, I'll show you something really cool that we just provided yesterday as a free online resource. It's an online QT calculator for all providers anywhere in the world to help them be smart about the QTC, or as we've said, hashtag respect the QTC. Amanda also asked, do we know of any cases where someone has died from the malaria drug as treatment? Yes. I became keenly aware of this just 2 days ago of a COVID-19 treated patient on combination therapy of what we call the Corona cocktail here of hydroxychloroquine and azithromycin. I don't like that combination, and we'll see what Elijah thinks about it. I can tell you that here at Mayo Clinic in Rochester, Minnesota, the combination of hydroxychloroquine and azithromycin, both, doesn't appear on any of our COVID-19 treatment algorithms that we're following for patients that we're treating. So the combination I'm very concerned about. We better be on our A game of identifying QT at-risk individuals. Elijah, your thoughts on that in general, hydroxychloroquine or the combination, the Corona cocktail? What do you think, Elijah?
It's a difficult question, Mike, because we are dealing as everybody realizes, with a lot of uncertainty, and we're trying to do, and physicians are trying to do their best for patients. I think the data from hydroxychloroquine and chloroquine was very interesting early on, particularly from the Korean experience, where they seem to be getting lower death rates from very early in their use of hydroxychloroquine and chloroquine. Unfortunately, none of the studies have really been able to address this sort of early treatment early in an early stage of the disease. And we really need randomized controlled trials to determine whether hydroxychloroquine will work in that effectively at that stage. And there are some ongoing. There's a big trial going on in the UK at the moment, looking at hydroxychloroquine separately from azithromycin and azithromycin as well as the combinations of ritonavir and lopinavir and also steroids. And I think we really need that data through as quickly as possible. But, you know, they've already recruited 3,000 patients to a target of 10,000. So I think we will potentially have answers very soon for these questions. I agree with you. The combination is very worrying. The limited short series that have published so far have shown that I think around 15 to 20% of patients are getting QT intervals that are in the worrying zone on that combination. And while those studies didn't report arrhythmias, as Mike has said, we do hear about them anecdotally just through contact with colleagues. So we do need to take care with the combination. If it is going to be necessary, they really have to follow the ECG guidance that Mike has published and that we've published, and that are also now going to be part of the various societies and health service guidelines.
And I think, like you, what we've tried to make sure families who don't get to come to visits right now because we're not business as usual, in all of the video consults that I've done with our long QT families, is I've given them my email and my cell phone and told them, if you get COVID-19, tell your primary physicians who are treating you that they have permission and an expectation to call me, so that we can decide together what are the treatment options, what's the risk-benefit balance, and do we think that their long QT is safe enough that we could handle a hydroxychloroquine exposure. So make sure you stay connected to your long QT physicians out there. Yeah, Elijah, go ahead.
Well, as you said, there are ways to optimize how well the patient is on treatment that can really minimize that risk. You've talked about in your own work, Mike, correcting the potassium to a high level for the patient. There are really important steps that could potentially still make it feasible for some of these drugs to be given for a patient who needs it.
Great. Well, we have a question from Monique. Hi, Monique, about zinc. You and I are probably hearing things about tonic water and zinc. Do you have any opinion about the potential role of zinc supplement in this whole coronavirus story?
I read some interesting data, although it's all very much experimental, in experimental models around how zinc may facilitate some of the actions of hydroxychloroquine, chloroquine in effects on coronavirus. And it seems it's a complex mechanism and seems to affect the way the virus reproduces itself. The problem is we're not certain that's the mechanism that's important in the disease, and there are no clinical data to say that's a good idea. Zinc seems to be a generally good mineral for the immune system, and people should be maintaining their general health and immune systems with multivitamins and good healthy eating anyway. But as to whether this is going to make a difference with chloroquine, I really don't think we have enough data there to be conclusive at all.
Right. Andrea, hi Andrea, and she's asking us, Elijah, Andrea has type 2 long QT syndrome, and she knows about paracetamol or acetaminophen for fever above 38 degrees. She's wondering, is it safe to take Tylenol or paracetamol with her beta blocker Nadolol?
Yes, it's completely safe.
I think that's a great question, because we don't want anybody wondering or worrying about whether acetaminophen would have any adverse interaction with their long QT or their CPVT therapy. So thanks for asking that, Andrea. Eve is asking us about, hydroxychloroquine has been used for malaria for a long time and used for lupus. And so what's the big deal in a way? And I've heard this a lot, Eve, from the standpoint of many physicians out there, unfortunately, many do say that these medications, hydroxychloroquine, are perfectly safe. And because of the malaria anecdote and the lupus observation, and in lupus, it's absolutely safe. They're right. But treating a lupus patient and treating a sick COVID-19 patient about to go on a ventilator, those are two completely different patients. I like to say that's not even apples and oranges, that's comparing apples and watermelons. So what might be safe hydroxychloroquine in lupus, we can't translate that and say this is a very, very safe medication for COVID-19 patients. Elijah, anything you'd add to that?
Yeah, I think it's important to also think about things like the dose of the medication that's being given. The doses that are being used to treat COVID are pretty high. And the doses that are used for long-term treatment and prevention of malaria and treatments in lupus are not necessarily at that level. In fact, it's a once-a-day treatment, a once-a-week treatment for malaria prevention, when in fact you're giving the same dose twice a day or once a day for 5 to 7 days in some of the treatment regimens that have been recommended. So the lower dose is going to have less effect on the QT, but it's also not going to have as much effect on the virus, if it does have an effect on the virus at all. So I think the contexts are very different. As Mike said, the patient context is different, but also the doses that are being used are different.
Ellie is a teenager, and it's great to have the teenagers and the young men and women throughout the world joining us as well. And she's joining us from Dublin, Ireland. I love Dublin. She has LQT2 and wants to be reminded what's the normal body temperature that we should be doing. I take my temperature every day, morning and night. We're required to at Mayo Clinic. So mine's 97 degrees. We're told that if ours is 100.5 degrees Fahrenheit, 38 degrees Celsius, that we cannot come into work. And so I think it's very reasonable to take your temperature if you want to. Elijah, are you guys doing that over there?
I think it's really just based on symptoms for the physicians or the medical staff. And so if you have any feelings of fever, to check their temperature from that point of view. So yeah, just below 37 degrees centigrade is normal European style.
And then we have somebody asking about the illness ARVC being high risk for COVID-19. And I think we'll do that as a plug and a teaser to rejoin us on Monday. We'll be having Hugh Calkins and his team from Johns Hopkins University joining us for a segment devoted not exclusively to ARVC, ARVD, and COVID-19, but a good piece. So I hope you'll come back and join us as we focus on COVID-19 for ARVC. Fatima is asking us whether we have any data of people who have died from COVID-19 and long QT. Elijah, are you aware of any long QT patients who have succumbed to COVID-19 yet? I'm not.
I'm not aware as yet, no.
So I think that's good. And I think all these measures, we want to keep coronavirus away from our long QT patients, all of our SADS families, for as long as possible, because every day away from it is one day closer to a therapeutic insight that we can know what is working, what isn't working. But no, we are at the SADS Foundation going to put forward a survey to all of our long QT families to see, have any of them come down with symptomatic COVID-19 and try to get a feel of that. But so far, I'm not aware. And I think, and Arthur Wilda isn't either. And I think among the three of us, we would have heard by now if there's been a long QT person who has died from COVID-19. So thankfully, no. And I hope it stays that way. Maxine is asking whether there's any advice, Elijah, for Brugada patients that you would give besides if you have fever, lower fever, and lower fever promptly. Anything else that you would want to tell our Brugada families?
Well, as I said, if the fever isn't being lowered, then there is a potential risk of rhythm disturbances, and some ECG monitoring will be necessary to ensure that that risk is reduced. So there will need to be contact made with either the emergency department or your physician, as I suggested before. The patients in general who are at most risk with Brugada syndrome are those who've had previous symptoms, may have had blackouts or cardiac arrest before. And in general, those patients will have ICD implants. And if there's an ICD implant already present, then that patient is protected from some of the rhythm risks related to a high fever in Brugada syndrome. So I wouldn't encourage patients who have a fever and an ICD and for Brugada syndrome to go to hospital or go to the emergency department at that stage. Only if they have a shock from their ICD should they immediately then contact their emergency department and physician. The risk of going to hospital and potentially picking up COVID if you've got fever due to something else would not be worth the attendance in hospital otherwise.
Yeah.
So it really comes down to people who don't have ICDs who may need to go to hospital, and you need to consult with your physician just to check whether they feel you may have enough risk to warrant going. Most patients will not have sufficient risk to warrant that.
I think that's great advice. I personally have been telling our Brugada families, if you get fever, lower it. But if you've been lifelong asymptomatic, don't go running into the emergency department. That's kind of the last place where I want you to enter social distancing and physical contact and being exposed. So use good judgment there. Maureen is unfortunately sharing us a tragic question because her son died suddenly while suffering from flu-like symptoms. So Dr. Behr and I were so sorry for your family's loss, Maureen. Their family, Elijah, is an LQT5 family. The gene, of course, is KCNE1. And they're wondering whether fever is a trigger for LQT5. I advise fever reduction for all of my long QT families anyway as a reasonable practice. Is there anything that you think of specifically in terms of fever and long QT in general, or LQT5 in particular?
I think there's very little evidence that can point to that as being a regular risk or trigger for long QT syndrome. So I don't think anything other than normal medication taken for fever is necessary in that setting. It's important, though, to continue taking all your other medication because that's going to give you the biggest protection. So your Nadolol still needs to be continued.
Thanks, Elijah. This is a good one, and it's from Allison. And Allison has type 1 long QT syndrome, but the way it was discovered is when her son was born prematurely from fetal bradycardia. And because of that, the cardiologist said, I think this must be LQT3 instead because of the slow heart rate. She says she has stress tests and shows no signs of QT prolongation. And can we point her in any direction? She's currently scared to exercise, but unaware if she's at risk. Well, that's a good one. It's loaded with some things in it. Elijah, you want to take a first quick stab at that one?
Well, I think there is still a small risk associated with long QT syndrome where the individual may have a relatively normal ECG even with exercise, but still carry the genetic variant that causes the condition in their family. Now, we're presuming, of course, that your LQT1 variant is definitely the cause of your long QT syndrome, or long QT syndrome in your child, and therefore in you. And if it is the case, then we would still try to give you beta blocker therapy to help reduce any small risk that is there. But please remember that if your ECG is normal at all times and you've never had a blackout, that your risk is actually low, and that beta blocker therapy will lower it even further, particularly for the LQT1 form of long QT. It was LQT1, Mike, is that correct?
Yeah, exactly.
So I would try your beta blocker therapy to give you some extra reassurance that it's going to be helpful. But rest assured that with some good medication and some careful management, that you'll be able to get back to exercise.
Great. Fiona Rose Elijah is asking us a UK specific question and wondering whether patients with long QT syndrome are currently classified as quote unquote vulnerable by the UK government. In other words, would they be advised to shield for 12 weeks? Do you know?
They're not regarded as vulnerable at this time, no.
Okay, thanks. And Amanda has type 3 long QT syndrome, and she's on one of the LQT3 directed treatments, which is mixilotine, and is wondering whether mixilotine has any potential negative interactions with COVID-19 that you would be concerned about, or should she continue to take her mixilotine?
Continue to take it. There aren't any concerns there.
Bonnie is wondering about her 15-year-old granddaughter who's scheduled to have a pacemaker defibrillator placed on April 24th, and whether we think it's safe for her to undergo the defibrillator surgery at this time due to SARS-CoV-2.
Well, my feeling is that we should continue to be treating patients who need to be treated, and we only put off patients who don't need to be treated urgently, and that we could delay till after the peak of the COVID crisis and reduce the risk of infection for patients. But most hospitals will have been endeavoring and working hard to ensure that they have pipelines and pathways for patients who don't have COVID and do have urgent conditions and can still be treated. And the most important thing is that we don't defer treatment that's urgent for people who need them, for patients who need them, because part of the risk of this crisis is that we don't treat other patients without COVID appropriately, and that we cause a hidden mortality, a hidden risk. So if your doctors feel that that your grandchild's case is sufficiently pressing to go ahead, then they'll be balancing the risk and the benefit. And so I'd really encourage you to go ahead.
And I think there, the one caveat, of course, that Dr. Behr and I have talked a lot about is what's the reason for the ICD in the first place. If it's urgent and clear, then proceed if it makes sense. But I think this gives us a good reason to take a quick point that most patients with long QT, with CPVT, with Brugada syndrome, most patients do not need an ICD. In our entire program of over 1,400 long QT patients, we are using a defibrillator in less than 15% of them. So it is possible that your granddaughter's ICD indication is obvious and clear and nobody would question it, but there's always a reasonable, this gives all of us a chance to pause and say, what's the reason for the ICD in the first place? Not referring just to your granddaughter, but I think, Elijah, you're seeing the same thing, and perhaps not to the extent that we're seeing in the United States, but pre-corona, an overzealous rush to treating these conditions with defibrillator therapy.
Yeah, I think it's always been a problem that we've tried to tackle. I think it's less of a problem in Europe and the UK. And the UK actually is one of the lowest implanting rates in the Western world compared to, particularly compared to the US and Germany, for example. So I think possibly less of an issue in the UK. But I certainly share your concern about ensuring that the ICD prescription is always appropriate, and if it's urgent, to be done appropriately and urgently if required.
And Amanda's asking a good question, that if they already have a defibrillator, does that give them enough safety margins to be treated with a QT prolonging medication like hydroxychloroquine, if in fact there is proven benefit, since there is the backup antidote installed? And it's a great question, and I completely agree with you about it, that it's not a one size fits all. So I don't think Elijah and I would want people to think that if you have long QT syndrome, you can never, ever, ever get hydroxychloroquine, no way, no how. It really is, what kind of long QT syndrome do you have? How much safety margin might there be because your long QT substrate is wimpy in you or is already maximally treated? So what we want to make sure is there's, we looked at today, there's over 160,000 people predicted in the United States to have long QT syndrome genetically, whether they know it or not. And we just want people with long QT syndrome, their physician providers, to respect your long QT syndrome a lot, so that careful deliberation is being taken as to how to treat the COVID-19 if you were to come down with it. Elijah, would you let an ICD patient with long QT get hydroxychloroquine if you were convinced that it works?
Yes, I think balancing the risk with the benefit, of course. I think the advantage of having an ICD, depending on the type of ICD, of course, is that the ICD can increase the heart rate. If it's the right type of ICD, a dual chamber ICD in that setting would be the right one. And that would be able to eliminate some of the risks that are associated with the effects of chloroquine and azithromycin on the QT interval. They're most risky when the heart rate slows, when you have something called bradycardia or bradycardia. And in that setting, that's when the risk may occur. So you may actually have a preventative measure in place with the ICD, as well as with all the things we've talked about before, monitoring the QT interval and also correcting the potassium and another particular salt in the blood called magnesium.
Great. Wow, it's amazing, Elijah, that we have about 5 minutes to go before I have to give some closing remarks, and the questions are continuing. This is probably one of the most lively group that we've had so far. Join us out there on SADS Facebook Live. So thanks for these questions. I wish we could answer every one of them, and we will pick up on these and new ones next week. But let's go. I'm going to do a 5-minute rapid fire with you alone, Elijah. So 5 minutes, we'll do as many as we can. Are you aware of any COVID deaths in Brugada patients?
Not yet, no.
Can you tell them what type of long QT syndrome Romano Ward is? So that's the old name for long QT syndrome, but Romano Ward is the same thing as type 1, type 2, type 3 long QT syndrome. They're all Romano Ward. Deborah's wondering if there's a greater risk depending on which version of long QT you have, whether you have LQT 1, 2, or 3. Any reason to think that one of them is a worse combination with COVID-19?
Well, the mechanisms of the drugs that are used to treat COVID-19 are quite mixed. So I think the risk is really going to depend on how long your QT interval is to begin with, and whether you've had symptoms in the past at all. So it's for me, I wouldn't want to differentiate the risk based on your genetic type of long QT.
And I think that's a good message, don't you? Is that paper came out a couple weeks ago now, which seems like forever ago, that said COVID-19 is far worse if you have heart disease. And we had an outpouring of anxiety and concerns among our SADS families because they started to ask questions like, is long QT syndrome a heart disease? Is Brugada syndrome a heart disease? And we had to say, time out. Heart disease, yes, but it's not the same heart disease that was published as being the ones with worse outcomes. And you agree, don't you, that there's no reason to think that our long QT families, our Brugada families, are at any greater risk of COVID-19 if they're otherwise young, healthy, active than the 70-year-olds with hypertension, heart disease, and heart failure, heart disease, and so forth.
I agree with you completely. I think we need to be positive here and know that there's a lot that can be done to support patients with genetic heart diseases who don't have underlying structural problems with their heart, such as the long QT and Brugada patients and CPVT patients. Really, the risk that they're talking about when they mention heart disease is where there is a structural problem in the heart that may predispose that person to having greater risk if they have complications of COVID, delayed complications of COVID. And that really doesn't cover the majority of our genetic heart disease patients.
Let me give you one final one, and because we've neglected one of the rarer channelopathies, so Susan is asking us, what about Anderson-Tawil syndrome? What about our families with those? And it's interesting you ask, because I just had a new consult today by video, so we are open for business, but by this new way of doing it, who just had to see the video camera come on and say, I bet you I'm seeing a patient with Anderson-Tawil syndrome today. So anything for our families with that rare disorder that you want them to be doing because of their Anderson-Tawil syndrome?
I think the message is just to keep on with your medication and try and make sure your potassium stays up. I think really focusing on keeping your potassium up will be important from that point of view, just in case there are any needs to treat you with the relevant medications that we've been talking about. Otherwise, it's just continue as you were and socially distance and avoid the infection as best you can.
Great. Elijah, I can't believe our 40 minutes has come and gone already. It is great seeing you. This brightens my day just to get to spend it with you. And I want to thank you on behalf of the SADS Foundation for joining us.
It's my pleasure, Mike. Thanks to you and the SADS Foundation, and thank you for all the interest and all the excellent questions.
Yeah, I think your questions out there were fantastic. And like I've done every time, I'm going to do it again. And this is for Elijah. This is my granddaughter. She's 73 days old today, and I haven't seen her since she was 20 days old. And so that's the look of being quarantined and not seeing her grandfather for 53 days. So that is her, everyone. And then somebody asked, and I'll show you, because you're going to be really excited about this. Everybody is working hard, and one of the things that we just launched yesterday, and you can get to it, and our physicians, more importantly, can get to it, is the new free online QTC calculator at www.covidqtc.com. This was great work from one of our trainees, Alan Strugru, who is the chief architect and behind the scenes put hundreds of hours into us rapidly building this calculator so that we could create a level playing field out there and help our providers on the front lines. Elijah knows well that some physicians, their QT knowledge is really, really good, and other physicians and healthcare providers, not so much. And so we're trying to make knowing your QTC value as easy as possible. So thanks for joining us, everyone. Elijah, again, thanks. And come back on Monday about the same time, I think. We're going to be joined by our ARVC specialist from Johns Hopkins University to start with a conversation about COVID-19 and what if I have ARVD or ARVC. But we'll take all of your questions, whether you have that particular genetic heart muscle disease, heart rhythm disease, or not. Until then, for many of us, today is a holy day of Good Friday. And so I wish you Good Friday blessings and Resurrection Sunday blessings for Easter. So until we see each other again, take care, stay safe, wash your hands 6 feet apart, and put a mask on in public. So take care, everyone.
Take care, Mike.
You
take care.
Give regards to your beautiful wife and those 2 incredible daughters of yours.
I will do.